Good afternoon, everyone. Welcome to Endocrinology Grand Rounds. This is our final Grand Rounds for the 2023-2024 academic year. And we're very pleased to have one of our own fellows present. Before his presentation, I would like to thank everyone who participated in these Grand Rounds, made excellent presentations, and specifically want to thank Dr. Carrie Kling for arranging the molecular endocrinology lectures and Dr. Kapoor Wintergurst for having arranged all the pediatric endocrine topics for the year. And we look forward to working with them over the next year. So today, Dr. Rohit Kulkarni, our senior fellow, will be presenting the grand rounds. Dr. Kulkarni graduated from Kashibai Nawale Medical School in India. Subsequently, he came to New Jersey, where he did his internal medicine residency. And as many of you are aware, when he did his last 2 years of residency in 2020 and 2021, it was in the heart of the COVID pandemic, and he did very well to do some work on COVID related illnesses. Had several presentations and publications on those. He came to us with very good recommendations, and over the last 2 years, he has continued to grow as a clinician and as a scholar. He had presentations at the Endocrine Society and other venues here as a fellow. And he has been an excellent clinician and also a very good teacher for the residents and students who always rate him very highly. And his patients also are very pleased to have him be their physician. Today, he's going to talk on the topic of parathyroid carcinoma. Dr. Rohit.
Good evening, everyone. Thank you, Dr. Mokshakandam, for your kind words. I'll be talking about parathyroid carcinoma today. This was one of the rare cases we saw during our tumor boards, and that's why I felt it was interesting. We've had multiple cases like pheochromocytomas. Also, we had like a bleed, which I'll be presenting at Endo Society, but this was one of the rare cases. That's why I wanted to discuss about it. I have no disclosures for today's presentation, and I'll be completing this topic under the following points. We'll start off with a case presentation, then we'll move over to basic sciences, anatomy, physiology, of course, because it's important in endocrinology. Biochemistry, again, is important when it comes to lab assessment. So we'll go over that. Then talk about the causes of primary hyperparathyroidism and also hypercalcemia. Finally, we'll move on over to genetic syndromes which are associated with parathyroid cancer. And finally, moving on to the management in terms of lab testing, imaging, and how to go forward with treatment. So we had a 60-year-old Caucasian female. She was presented to University Hospital with referred for hypercalcemia. She did not have any symptoms, but in terms of her medical history, she had GI issues, IBS, GERD, obesity, and also some skin issues, atopic eczema, as well as alopecia areata. And for that reason, she was on methotrexate. Also, she had some spinal stenosis. So no symptoms of hypercalcemia. She did have a ankle fracture, but this was secondary to a motor vehicle accident in the remote past. But otherwise, no fatigue, no polyuria, no polydipsia, no changes in mental status as well. Family history was negative, no endocrine pathology. She didn't have any family history of hyperparathyroidism, pituitary tumors, any duodenal or pancreatic tumors as well, and some surgeries like tubal ligation. Um, just some alcohol use once or twice every week, but otherwise no allergies, no other toxic habits. Um, when it comes to hypercalcemia, we want to look into the medications, two of which are very important. One is lithium, and the other one is any diuretic, especially thiazides. So the patient wasn't on any hydrochlorothiazide or lithium. The medicines are listed. The ones like Kenalog, it's not that important when it comes to hypercalcemia. And methotrexate, she was on that as well. Review systems were negative. Same with physical examination, nothing major found on that. So when she presented to us, that's the denoted labs. So we did the labs in late December, and you can see that the calcium was slightly on the higher, like mild hypercalcemia, 11.3. She also had an albumin of around 4.2, so not bad. Vitamin D was on the lower side, which was later on repleted, and PTH was elevated to 172. Magnesium, phosphorus levels, these were later on in the disease, but they were normal. And you can see prior to her presenting from 2 to 3 years, she already had hypercalcemia, and that's why she was referred. Later on, she had surgery. So you can see here that the intra-op levels of PTH actually reduced. And later on, when she was followed up, in fact, her levels started increasing and she had recurrence of the disease. So this is a slide just about her timeline in terms of her labs. Initially, calcium was not too bad, 10.7, slowly started creeping up. Maximum was 12.2, and that's why she was referred to us. It was 1 milligram per deciliter above the normal limits, and that's why she came in. Later on, she had surgery, and the labs dropped. And finally, when she had the recurrence, these levels again started going up. Uh, we also did a 24-hour urine calcium and creatinine just because you want to rule out even FHH or familial hypocalciuric hypercalcemia. And our levels were again in the normal range around 150. The total 24-hour calcium and 24-hour creatinine was again around 1. And the volume was also around 1.3 liters. So we need to even look into the volume status. Um, but in the past, in terms of imaging, she did have um, some elevated LFTs, and she was being monitored by the GI team because of being on methotrexate. And at that time, we found ultrasound. It did not show any nephrocalcinosis, no asymptomatic stones, and she just had the steatosis, which is there due to obesity. We also she underwent a DEXA scan, and you can see that she had osteopenia. It was minus 2.1 in the spine and minus 1.6 in the radius. And the radius we usually do the distal one third of the non-dominant hand. So in her case, the left hand. So she did have some osteopenia. Finally, she was referred to endocrine surgery with Dr. Javed, and we did an ultrasound at the office. In the office, she did have multiple thyroid nodules and also had a posterior right-sided parathyroid growth, which was 1.5 centimeters in maximum diameter. But she did not have any abnormal lymph nodes. So preoperatively, a diagnosis was made of PTH-dependent hypercalcemia, and this was most likely secondary to primary hyperparathyroidism. Uh, she was referred to endocrine surgery and finally had the surgery done in mid-May, and it was resected for possible right superior adenoma. So before surgery, it's very tough to come to a diagnosis of parathyroid carcinoma, and this was seen mainly on histopathology of the surgical sample. And here you could see the main thing what we see in parathyroid carcinoma is there should be some invasion, and the patient did have invasion, so that defines that the patient has parathyroid cancer. We'll also go over the definition, WHO definition, later on, but she did have frequent mitosis, these thick fibrotic bands, necrosis as well. Moving over to parathyroid anatomy, we usually have four parathyroids in humans, and it develops from the third and fourth pharyngeal pouches. Uh, they are usually around half a centimeter in size, and they usually are lipid rich. So they have it's brown in color, especially when you're doing surgery. And if you see any grayish discoloration, that's sometime, or if it's very hard, that's the time you want to think about uh, uh, cancer. So we have a quick question on which of the following don't have parathyroid glands. Are they birds, whales? You can look at my neck. I probably you can see if I have any scars, but the other thing is lions, fish, and lizards. Any whales? Whales, two people for whales. Fish. So the answer is fish. So parathyroid evolution actually developed when life form on Earth transitioned from the water to land, and that's the time when we needed parathyroids for calcium phosphate homeostasis. So it's present in reptiles, birds, mammals, some amphibians, but it's not present in fish. This is a normal histopathology of the parathyroid tissue. We can see there are a lot of adipocytes, and these adipocytes depend upon how the patient's habitus is. If they are more obese, they'll have more adipocytes. You can also look, there are clusters of cells called the chief cells, and these chief cells are the ones which produce parathyroid hormone. They also, in turn, change into the oxyphil cells. Oxyphil cells, we do not know much about their use or what do they do in the body. This is biochemistry. I hated biochemistry, but it's very important for us to know, especially because of testing and to integrate it with our uh, lab results. So in the top portion, you can see the human portion of the parathyroids. It is secreted from ribosomes on the endoplasmic reticulum, and this is secreted in a large peptide hormone. So it's pre-pro parathyroid hormone. The pre component has around 25 amino acids. The pro component has around 6 amino acids, and the actual parathyroid has 84 amino acids. On the right side of the image, you can see the actual parathyroid hormone. It has a amino terminus, and it also has a carboxy terminus. This is important because our testing depends on where these antibodies attach to. So our first generation testing, they used to test only the carboxy terminus, and that's why even when the PTH is degraded, the inactive forms are also picked up by the first generation testing. Whereas the second generation testing, it takes a look at both. It's a sandwich assay, and it looks at the amino terminus as well as the carboxy terminus, and that's why it can detect the entire or intact PTH. They're also working on third generation testing, in which they're trying to test only the amino terminus fragments of PTH. It's seen in certain case reports that in parathyroid cancer, the amino fragments are actually secreted more. So that's something which they are doing new, the third generation PTH testing. So you can see it's an 84 amino acid peptide hormone. It's secreted by the ribosomes on the rough endoplasmic reticulum, undergoes translation, and then finally organized in the Golgi apparatus as pro-parathyroid. Further on, it's broken down as PTH and then stored in these secretory granules. Some of these secretory granules also have proteases, and these proteases break down the PTH and render it ineffective. So whenever the calcium levels are very high, that's the time these proteases will act on the PTH and degrade it. So that's why the ratio of secretion when these granules secrete, the PTH is less, and the inactivated degraded forms of the carboxy terminals are high. Um, so intact PTH is the active hormone, and these degraded carboxy terminals are the ones which are inactive. As I mentioned, if calcium goes low, that's the time there's increase in intact PTH secretion and decrease in the fragments, and vice versa. Um, Also, intact PTH is degraded in the liver as well as the kidneys. That's why it's important when it's degraded by the kidneys. If patients have chronic kidney disease, these levels can further increase. Moving over to the calcium sensing receptors, they're present in, of course, the parathyroids, the kidneys, and they're also present in the C cells of the thyroid. Uh, you can see that there is a extracellular domain which is large, and this is a G-coupled protein receptor. So you have adenyl cyclase there as well as which is inhibited, and there is an increase in phospholipase C. And through multiple intracellular mechanisms, PTH is finally secreted. This is the normal homeostasis. We cannot do without it in endocrinology. It's a bread and butter, the positive and negative feedback. So decrease in calcium is sensed by these calcium receptors, and this finally increases PTH. PTH acts on three major organ systems. One is the bones, where there's a resorption of the calcium and it's increased in the blood. The other thing is it also acts on the kidneys and it promotes conversion of vitamin D to its active form. And this active form helps in absorption of calcium phosphate as well. And that's how it increases calcium. You can also see on the top, on the right side in figure A and B, we have plotted PTH versus calcium. Figure A is just the plots, whereas figure B is the logarithmic similar plots. And it's a sigmoid curve. And you can see that it has three major slopes. One is maximal, which is A, is maximal secretion of PTH, and it's usually below when the calcium is very low. The other phase is the opposite, where there's a minimum secretion of PTH. And you can see one thing important to note is that it's never zero. So even if the calcium levels are high, you always have some amount of PTH which is still secreted. And of course, in between is where it's trying to maintain it in normal individuals to keep it within the normal limits. The next graph is the similar thing. They've just changed, flipped the axis, but it's still a sigmoid shape graph. Uh, Moving over to hypercalcemia, when the patient comes to us, we want to evaluate. Of course, if the levels are very high, they're having symptoms, we want to treat them. And we, of course, draw labs prior to treatment. But in most of the cases, you want to always review medicines. You also want to make sure that the calcium level is appropriately normal. So you want to look into the CMP, look into albumin. Many people have elevated albumin, and that can falsely show that the calcium is also high. So you repeat labs, and then finally you want to delineate, is this dependent on parathyroid or not? And that's why we do parathyroid levels. If these levels are very, very high, then it points towards primary hypoparathyroidism. If it's in the normal range or slightly high, it can be primary hypoparathyroidism, or it can also be FHH or familial hypocalciuric hypercalcemia. And of course, if it's low, then it's PTH independent, and you want to look at other causes. It can be cancer associated when PTH-RP is elevated. It can be secondary to increased 125 hydroxy vitamin D. That's seen in sarcoidosis, lymphomas, and again, some people can take a lot of vitamin D, so you want to check that and make sure it's not at toxic levels. Other causes can, of course, be multiple myeloma if these all have been negative, and vitamin A intoxication can also cause it, as well as hyperthyroidism. So moving over to PTH-dependent hyperthyroidism, we are mainly going to talk about primary hypoparathyroidism, and they can be either most commonly parathyroid adenomas, which account for around 80% of the cases. It can be two gland involvement or diffuse hyperplasia as well in around 20% of patients. And very rarely, parathyroid cancer is one of the causes of primary hyperparathyroidism. Parathyroid cysts in generally do not cause it, but rarely can cause it as well. So this was a study done. It was a big systematic literature review of around 20,000 patients, done here in the US between 1995 to 2003. And they noted that amongst these 20,000 hyperparathyroid patients, around 89% of them had adenomas. Dual disease or multiple gland disease was seen in around 9% of patients, and around 1%, which was like 1 to 2%, they used to say was the incidence of carcinomas, but it showed around 0.75%. So going back into history, who described parathyroid cancer for the first time? So this was Dr. D. Quervain. Anybody know why he's famous in terms of any names with D. Quervain in our Yeah, so that was De Quervain's tenosynovitis, the extensor tendons. That's one thing. And another thing in the thyroid, thyroiditis. So subacute De Quervain's thyroiditis, those were named under him. There have been other De Quervains also, but this was the individual who described this, as well as parathyroid cancer. In fact, the parathyroid cancer case which he presented was of a non-functional parathyroid cancer. Usually all these cancers are functional. Around 90 to 95% are functional. He described a case of non-functional parathyroid cancer in which they just had swelling. Um, and it was described in 1908. This was the case. I couldn't find the patient's name, but patient's name GK. He was 68-year-old. He presented with this parathyroid, like a large mass, and in Dr. De Quervain's journal, which was Parastoma maligna aberrant, or also in English like parathyroid aberrant parathyroid malignancy. He described this patient with a right-sided mass. It was painless. The patient just had some headaches, but otherwise no issues overall. Um, and parathyroid cancer is very rare. Amongst all the endocrine malignancies, it's one of the organs which is the least involved, around 0.05% of all the cancers. It's equally seen in males and females. Uh, Based on the largest study in the US, 57 years is approximately the median age, and it accounts for only 1% of the cases. It's rarely, it's possible, but rare that it involves all the glands. So usually only one gland is involved. Moving over to epidemiology, so this was a study done here. It's close by in Indiana University, Indianapolis, and it was looking into the incidence of all various cancers. You can see through this that thyroid cancer, of course, had the highest incidence rate, and it was seen maximum more in females as compared to males. Next on the list was pancreatic cancers. These were all the cancers. Um, so both well differentiated as well as the secreting tumors. And next was adrenal tumors, and the least common was parathyroid tumors. The incidence rate was 0.36. The other functional pancreatic tumors, however, they have lower incidence rate as compared to parathyroid cancer. This was looking into the incidence of parathyroid cancer. Initially, the incidence rate was very less, but with more testing, eventually we found out that calciums were higher, and many of these patients were asymptomatic, and there was an increase in the incidence. So it increased from 3.5 later on to 5. Uh, After some time, there was actually a dip in the incidence, probably because we tried to get all the patients, but now the incidence is actually increased to around 10 to 13 per 100,000. Same in this study, it was equal, exactly equal. I don't know how they got it, but 50-50% in males and females. It was done at University of Minnesota, so it was predominant in the Caucasian population, and it was mainly seen between 45 to 60 years of age. Similarly, this was the largest US retrospective study. And this was done in 2014. Similarly, you can see that the mean age was around 57 years, and it was almost equally distributed in males and females. Um, when it came to prognostication, as per this study, they said that if the patient's age was lesser, they had better chances of survival. And same with comorbidities. If they had multiple comorbidities, they of course had worse prognosis. They also looked into lymph node status in this study, and they saw that if the lymph nodes there was any spread, then the patient had lesser survival. Moving over to another study which was done not in the US but in Korea. This was done in 2000 between 2002 and 2017, and there they found that the average age was around 53 years. Again, this study showed that females had more likelihood of getting it. So 60% of the patients were females. So in short, it's equally distributed amongst males and females as compared to uh, adenomas. In adenomas, it's more common in females. The age group is around 45 to 65, and the incidence is climbing up slowly. When it comes to molecular pathogenesis, there have been a few genes implicated. The most important is CDC73. It's also called as cell division cycle 73. And this accounts for a protein called parafibromin. Parafibromin is a tumor suppressor gene, and it prevents proliferations of the parathyroid cells. So this is something which is important in terms of genetic testing. Other genes, MEN1 syndrome has also been implicated, GCM2, and the FLCN gene. I didn't know about this syndrome. It was Burt Hodge Dube syndrome, but that's also associated with parathyroid cancer. We all know MEN1 syndrome, the three Ps. So you have mainly primary hyperparathyroidism. You can have pituitary tumors, and the last thing is you can have pancreatic tumors as well. Um, and elevated PTH is the most common amongst all of these. So there have been multiple case studies here in Mayo Clinic as well as MD Anderson, and they looked into these patients with MEN1 syndrome. Similar study was also done in Beijing, and they found that amongst all these patients who had primary hyperparathyroidism and MEN1 syndrome, only 1% of the cases accounted for carcinoma, but it is prevalent in MEN1. Next one is Burt-Hodge Dube syndrome. They have a triad mainly of skin lesions, which are mainly in the form of fibrofolliculomas. That's the most commonly seen lesions, which you can see on the right. They also have pulmonary cysts, which are multiple bilateral. Renal cancer is possible, and other cancers, which are rare, but parathyroid cancer is one of them. Um, this is hyperparathyroidism, jaw tumor syndrome. They usually referred from a dentist to us because the dental individuals are the ones who first do the scan. And as you can see here, there is a lesion, and that's a ossifying fibroma. So they're referred to us for that. These patients usually again have the CDC73 mutation, and they have fibromas, renal lesions, uterine leiomyomas, or even cancers, and they can also have parathyroid neoplasia. Amongst the parathyroid neoplasia, around 85% are adenomas and 15% account for carcinomas. Um, and they usually present earlier in life. The other thing is familial isolated hyperparathyroidism. They weren't able to find a lot of genetic reasons for this, but all the genes which we talked about were implicated for this. Um, Moving over to clinical presentation, as we discussed, it depends on whether the tumor is secreting parathyroid, if it's functional or non-functional. The first case was of a non-functional tumor, so they mainly presented with a mass. But 95% of these patients have functional tumors where they're secreting intact PTH, and they get all the signs of hyperparathyroidism, in which there are bone manifestations, renal manifestations, of course, generalized fatigue, neuropsychiatric issues. Many of them are asymptomatic. Our patient was also asymptomatic, which we did have, and many of them present with a neck mass also. Um, so non-functional tumors are again very rare. They are usually normocalcemic because they're not having PTH. They present with a neck mass, and it's already progressed so much that they're already in advanced stage of disease, and they're also a bit more aggressive as compared to the non-functional tumors. These usually metastasize to the lungs, the lymph nodes, liver, and bone. Our patient actually finally had mets, bilateral mets to the lungs, and needed some wedge resection, which did show parathyroid cancer. Um, so how do we differentiate preoperatively between parathyroid adenoma versus parathyroid carcinoma causing these symptoms? It's very tough to say this, but there have been certain pointers which can point us towards that this could be carcinoma. One of which is if they're having both symptoms, renal and skeletal symptoms. In many studies, they've found out that if you're having that, the chances of cancer are higher. Um, the other things are, of course, if the calcium level is way too high, above 14, so that's severe hypercalcemia, or PTH is also more than 10 times your normal limit. And sometimes when they're going for surgery, if you see some discoloration, if the nodule is hard, or you see some frank growth outside, that's the time you want to think about cancer and do en bloc resection. So same in the table, you can see that these patients have higher levels of calcium, parathyroid. In terms of symptoms, they have renal and skeletal involvement both concomitantly. And of course, when you're doing the biopsy, you see all the results in cancer, fibrosis, inflammation, atypia, mitosis, of course. This was a similar study where they found out that if you're having both the renal and bone manifestations, you should think about it. And especially if you're having it concomitantly. If you're having just one of them, it's less likely you have it. But if you're having both, it is likely carcinoma. In terms of labs, you want to do a CMP, PTH, vitamin D, 24-hour urine calcium, as well as creatinine to rule out FHH in terms of diagnosis and the other causes. Some people also do bone markers because, like our patient did have osteopenia, so you want to even monitor that, but it's not recommended to do regularly. Um, you want to always make sure that the patient is not on thiazides, lithium when they come with hypercalcemia. And when you check the PTH level, again, as we said, um, if it's very high, then it's most likely primary hyperparathyroidism. If it's in between, you also want to do workup for FHH, and that's the time when you want to do calcium to creatinine ratio. And that's the formula. We put in the numbers. For our patient, again, it was in between. So on the right side, you can see the results, the equivocal results, which are between 0.01 to 0.02, which our patient actually had. So ideally, the patient did need some FHH testing. But another thing, what you can do is just monitor the labs. And the patient did have serial labs for 3 years, and it was always high. So it's most likely primary hyperparathyroidism. But if this level is less than 0.01, that points towards FHH. And if it's above 0.02, it points towards primary hyperparathyroidism. Uh, the AAES, or American Association of Endocrinology of Endocrine Surgery, came up with these guidelines, and they want us to do the similar testing where you're doing calcium, PTH, creatinine levels, 24-hour urine calcium and creatinine. Patients who are asymptomatic, you also want to look for disease advancement, like you want to see if they have kidney stones, nephrocalcinosis. So you can do a ultrasound, X-ray, but ultrasound is preferred, and also a bone mineral density to see if there's any resorption of bone. Um, the imaging modalities are usually ultrasonography. That's the cheapest amongst a lot, and it can you can see on the right side that you have this hypodense lesion, which represents the parathyroids above the normal thyroid gland, and it's posteriorly placed. So you can see it's increased in size around zero point 0.9 centimeters. That's one modality which is the cheapest. The other things are system AB or otherwise technetium scans. It can be done with a SPECT scan. If that's also negative, 4D echo can also help. Another thing important to know is that the sensitivity of all these testing is low. So if the patient does have biochemically positive for hyperparathyroidism, but the testing, like the imaging is negative, still you should always refer the patient to endocrine surgery, because sometimes you need to do an exploratory neck dissection and see which of the glands is enlarged. When it comes to FNA, I thought probably FNA will help, but I looked into the guidelines. They say FNA actually does not help because you want to look into invasion. That's the criteria for cancer, which you cannot find on the FNA. And also, there is risk for seeding. If there's any bleeding, it can seed into the vessels and cause metastasis as well. This has been the previous definition. Like we should just look at the histopathology, where you look in the on the left side, you can see these fibrous thick bands which are seen in parathyroid cancer. A lot of atypia is also seen, and on the right side, there's some PTH staining done. However, these were older terms, and now the WHO in 2022 has come up with guidelines in which it has to be diagnosed only if invasion is present. There has to be invasion of blood vessels, nerves, or local tissue, and only then you can consider diagnose as parathyroid cancer. If there's no invasion, but you still have all these things, it's something called as atypical parathyroid tumor, where there's no cancer as yet. So that's the same thing, the WHO definition. There has to be some sort of invasion, angioinvasion, lymphatic, neural, or local spread. Um, this was done in 2022, and first on microscopy, you want to look into the features. If the features are present, like mitosis, it's either atypical parathyroid tumor or cancer, and the differentiation is just the invasion. Generally, if PFIB, you want to also do PFIB staining. If PFIB is negative, then they're at a higher risk for atypia. So that's the time when you can think about genetic testing also if the PFIB is negative. Um, and that's the same thing in adenomas. PFIB is generally positive. APC is also a tumor suppressor gene, and that's why it's always present. when they get deleted, like in atypical parathyroid tumors or parathyroid cancer, the risk for worsens. So that's why they are usually negative in cancers as well as APCs. For atypical parathyroid tumors, it's in between. It can be present or it can be deleted. Moving over to prognostic factors, so in the some studies they've shown that tumor size is an important thing. Age also, younger age have better prognosis. This study did not show anything about lymph node involvement, but a previous study did mention that if there is lymph node involvement, they have higher uh, the risk in general. But the AGCC has come up with a temporary TNM classification, but they also do mention that we don't have, it's such a rare tumor that we don't have enough data to actually give a indic, prognostic staging. And finally, moving over to the treatment, treatment is mainly surgical. Uh, these patients, if we have suspicion prior to um, surgery, you want to do a en bloc resection. But most of these cases, we don't know until and unless the pathology comes out. So they undergo mainly simple parathyroidectomy. And after they've underwent further resections, if we're not able to control the hypercalcemia, like in our patient, we started the patient on Cinacalcet. It brought the calcium PTH also down, but then the patient started to develop GI side effects, and that's why we had to stop the medicine. Uh, but if we can't control it surgically, then there are multiple medical options which we'll talk about. Preoperatively, like in the hospital, you want to make sure if they're having severe hypercalcemia or parathyroid crisis, we're treating them with IV fluids. We give them around 200 to 300 cc an hour, especially if they don't have lung issues or heart issues. Um, if the levels are very high and they have heart and lung issues, you can even think about dialysis if calcitonin, bisphosphonates, or denosumab doesn't work. Um, Finally, when what type of surgery to do? It totally depends on when we suspected the diagnosis. So most of the times in blue, that's what happens. We diagnose it post-operatively. So they all undergo parathyroidectomy, and we see on pathology that they have this invasion, and that's why they undergo retreatment or resurgery. And there's no consensus in terms of whether to do dissection in terms of neck dissection, lateral and central neck dissection. But AAES says that you don't need to do central neck dissection, you can do just lateral neck dissection. And of course, preoperatively, if you diagnose, then you want to do an en bloc resection. Uh, Suppose the patient has these mutations, the CDC73, and you find this in the patient's relatives, then how to go forward with surgery? That's another question. But there hasn't been any consensus on this as well. Usually, you refer them to endocrine surgery, and they'll take a look all bilaterally. And if they see anything which is suspicious, like there are cysts involved, any hemorrhage, that's the time they'll take out the respective gland, again, en bloc. And for recurrent disease, sometimes palliative resection is done. Our patient did have bilateral Mets, and she underwent um, wedge resection of a couple of lesions. So these are the guidelines given by AAES again. They want en bloc resection without capsular breakage. They do not recommend prophylactic dissection, neck dissection, and in terms of external beam radiotherapy, they do not want us to give it because once we give external beam radiotherapy, the patient develops a lot of coagulative necrosis and there's a lot of fibrosis post surgery. So if there is any recurrence, you cannot go again and reoperate. The risk of injury again to the nerves is high, so you don't want to give external beam radiation. It's only given in some cases where you have done all surgeries multiple times, calcium levels are still high, PTH is elevated, and just for palliation. Um, but routinely it's not done. Uh, so again, radiotherapy, it's not routinely done. It's again not a very radio-sensitive tumor, so no point also giving the radiation. This was a study done on amongst 80-85 patients, and amongst them, 126 or around 14 to 15% underwent EBRT or external beam radiation therapy, and it showed that there was no difference in overall survival with all the statistics, crude multivariate models. There was no improvement with EBRT. Moving over to chemotherapy, it's again not a very like sensitive uh, tumor to chemotherapy. And there have been multiple regimens used in the past. As they noted in the papers down, they've used nitrogen mustard. They've also used combination therapy with actinomycin, cyclophosphamide, vincristine, 5-fluorouracil, but it was never sensitive. So these patients are not sensitive. There was only one case report where the carbazine, 5-fluorouracil, and cyclophosphamide just prolonged the life of the patient. Moving over to medical therapy, that's when we come in. We mainly rely on bisphosphonates and calcium mimetic agents. Um, Calcium mimetic agents are usually given if the patient's not having severe hypercalcemia. If it's mild, less than 12, you can start off with calcium mimetic agents like 30 milligrams of cinacalcet twice a day and escalate the dose. If you're not able to control the hypercalcemia, then you can always add bisphosphonate or zoledronic acid, and also denosumab, depending on insurance. However, if the patient initially presented with symptoms or the levels are very high, above 14, you don't want to start off with cinacalcet. You want to start off with the bigger guns like bisphosphonates or denosumab. Um, and these are the recommendations by Endocrine Society. It's basically saying if they are on one of the drug, you should always add another drug like bisphosphonate or denosumab. And if they've been on denosumab or bisphosphonate, just add cinacalcet to keep the calcium down. But most of these patients actually over time get resistant to your bisphosphonates, and then we have to transition them to denosumab. They actually eventually pass away due to hypercalcemia, not due to the metastasis per se. Uh, they have also used disodium chlorate in the past. There have been studies in terms of which bisphosphonate is better. In the past, these are older studies. So pamidronate was amongst the bisphosphonates which was used uh, previously, but later on studies did show that zoledronic acid has better outcomes than pamidronate. And in terms of hypercalcemia of malignancy, even denosumab works. So that's why nowadays the first line treatment is zoledronic acid or denosumab. If the patients are resistant to denosumab, then to zoledronic acid, then the dose of denosumab, however, is much higher. You want to give like 120 milligrams subcutaneously. In terms of future therapies, they're still working on a lot of future therapies, but there was one study on AZT or azithromycin, and it induced apoptosis as well as decreased the cell growth. But this was all done in vitro, so we need more in vivo studies for seeing how this drug works. They've also found out that they've used anti-human PTH antibodies to try to reduce the burden, but these are all just case reports. You can see there are three plus the fourth case report. They were just done in individual patients. So there's no control trial, but they use this anti-human PTH to decrease the symptoms as well. So just in short, it's a very rare malignant tumor. In terms of the genes, we need to know that CDC73 plays an important role. Other genes are rare, like MEN1 syndrome. It accounts for only 1% of the cases and equally distributed in males and females. Uh, Mainstay treatment is surgery followed by medical therapy if they're not well controlled. But in terms of chemosensitive and radiosensitive, these tumors are not chemosensitive or radiosensitive. And I would like to acknowledge Dr. Sibai, Dr. Javed, Dr. Krishnasamy, and our entire endocrine team. Um, these are my references, and this is today's event code. Any questions? Yeah. Uh, So it was 1.5 centimeters, the biggest diameter. Uh, the patient did have angio invasion, but finally the patient underwent ipsilateral lobectomy also on that side, on the right side. They underwent resection on the right. Lymph nodes around 4 or 5 were taken out. All were negative. But later on, the PTH levels, calciums improved, and 6, 7 months down the road, they started increasing again. And that's when we did a repeat scan and saw they had bilateral mets to the lungs. So usually you just take out one. It's not seen in it's not a multi-gland disease. However, if the patient has these mutations, then most likely it can develop in the other glands also. So that's why you want to keep an eye out on these patients, do regular CMPs, PTH, phos levels, and keep a tab on them and account them. But if they have the mutation, yes, it's possible to have multiple glands involved, but usually it's not seen. It's usually just one gland which is having the cancer. Yeah, the original one was not. That was another thing. Like the assay, we don't know if it was. I was trying to find out more about that case, but I was not able to uh, find. But it was non-functional. I was surprised, but it was a big, yeah, big tumor. Uh, yeah,
There was no, like, with that bigger mass, you'd imagine there'd be huge amount of symptoms too.
Yeah, plus the calcium would be great.
Yeah.
but that patient didn't have like PTH being elevated, so it was non-function. So the calcium wasn't, at least they had mentioned it wasn't high. And that's what they're saying, non-functional tumors are usually normocalcemic. So it's very tough to pick them up unless and until. Yes. So currently, our patient was referred to uh, ONC, the ONC team, and they are sending PD-1 ligand. That's something new. There haven't been any studies, but that's something new that if they have this receptor, they can think about starting pembrolizumab, possibly. But that's the next thing they're doing. They're sending the patient for PD-1 testing as well as genetic testing. I couldn't find genetics. That's what I asked Dr. Sibai, but I couldn't find genetics on this patient. But the latest, like the ONC folks, they did send, that's what they were writing in the notes, genetics and PD-1 ligand. Those are the two things they were sending. Patient was asymptomatic. Calcium was 12.2. PTH wasn't too high. It was, yeah.
PTH was 600, calcium, they get admitted with acute hypercalcemia, like 16 or 17. So,
But
but
then-
the sun was
It
very,
was very odd, and it was like completely, almost circumferentially free, apart from one little area. And I remember I usually went
even
to,
listed in a
Yeah.
frozen or something. We
Yeah.
don't think of doing.
I wouldn't have even thought of it, but to be honest, Dr. May said it probably wouldn't have helped anyway, because you need the whole.
Yeah.
But it was like, there was one area that it was a little stuck into the thyroid, and I increased my incision from 2 centimeters to 2 to like 2.5, 3, just because I wanted to get a bit more of the thyroid part dissected. But that's not unusual for parathyroid. They can actually be intrathyroidal,
Yeah.
either wholly or partially, so it was really odd. And but when we discussed it at Sugarboard, Dr. Sabah mentioned there's some studies that talk about incidental findings like that. Like you were totally surprised about.
Yeah, most of the cases, they found like it's an incidental after surgery. Like to suspect that it was before surgery. Sometimes it's not.
Classify this into like atypical Parkinson or any this that would have as per what you mentioned, the
The patient did have angio invasion. So if they have in any sort of invasion, that differentiates from the atypical adenoma, where they have those histological features, but they don't have invasion. So this patient did have invasion. So it was, they also sent the test to like Michigan, University of Michigan. They also said it's cancer.
It isn't there.
They sent it anyway, just to appease me, and in fact, it was helpful because they re-looked at the slides and it turned out that there was an area of cancer outside the gland, which meant that it wasn't necessarily completely resected, which is why we went back in.
We were just talking about the presentation. This was pretty atypical. Patient's calcium wasn't terribly high. PTH was also not very high, and that's what we are discussing. In terms of questions, I see any treatment with radiation has any benefits. So there hasn't been any. This is a very not radiosensitive tumor. So radiation therapy is only given for patients for palliation purposes. But otherwise, there haven't been any benefits of EBRT as denoted in the previous paper. Another question by Dr. Winters is how often are HPT, JT mutations found? So I have not I didn't look into that, but I'm sorry, I'll have to look into more. Yeah, so amongst HPT-JT, the people who had primary hyperparathyroidism, only 15% accounted for carcinoma. But I don't know how often do you see these mutations in HPT-JT tumors, the CDC73, how often do you see it? It's associated with it, but I don't know how many percent of the cases. I'll have to look into it. And the last question is just to clarify, if one gland has carcinoma and it is removed and controlled, the other glands are typically not removed prophylactically. That's right. So if yeah, so if the patient just has one gland carcinoma, you don't want to operate on the other ones unless and until you suspect that it's increasing slowly. Very rarely you can have other glands also involved, but you want to recheck them with biochemical analysis and again do a scan if need be, if the levels are going higher. But typically it's not removed. So there are like there's no data because it's rare also, and they said that no one is like completely cured, but 5 years of
That's a jaw tumor guy.
It's not a jaw tumor. It is parathyroid cancer. It was, he had surgery and it's been more than 10 years. It is, so what's the,
so the 5 year survival I saw in one of the papers, it was between 60 to 70%. 5 years survival. So it's pretty good. But again, if they have metastasis, it's issue is the hypercalcemia and the other comorbidities. When they have that together, that's the time they decompensate and pass away because of the hypercalcemia, not per se because of the metastasis. Yeah, so her levels were good. Calcium, parathyroid came back to normal. Vitamin D, PTH, everything was good. But 6 months down the line, it started going up again. And then we did a system EB scan and lit up in the lungs. So dialysis, they only say in the acute hypercalcemia crisis.
oh, right,
Yeah,
and calcium, if hypercalcemia is the cause of their mortality,
correct.
is there a point?
I didn't see any. Yeah, but so they said that as a disease, correct. So you can again repeat it. They mentioned that as we keep giving zoledronic acid, they actually get little resistant to it, unfortunately. And then you have to double up the dose of the denosumab when we're switching them. Yeah, it was surprising. This case, the levels were so low, nothing went with whatever I read up. Not like preoperatively, you couldn't say that the patient had cancer. Too. Plus, again, another thing, these studies were all done previously. The classification is just changed in 2022, where they said that we want invasion also. Whereas previously, they just looked at atypia, necrosis, and the histopath. They never commented on invasion also. So that was another thing which probably by putting this criteria, we're making it little more rare also. Or maybe it's just the same spectrum.
I think that's all. That's the thing. That's
Yeah.
classification. Very good, great overview.
Thank you.
Thank you.
Thanks.